Welcome. I hope you're having a great day. I usually do not lecture on the physiology of various body systems in relation to drug effects. I do feel, however, that the receptors and their functions are very important in understanding many of the drug classifications. So this one time, I'm making an exception. The central nervous system consists of the brain and spinal cord. The peripheral nervous system consists of motor neurons and sensory neurons. The motor neurons are divided into the somatic motor system and the autonomic nervous system. The autonomic nervous system is further divided into the parasympathetic and sympathetic nervous systems. The sympathetic nervous system has adrenergic receptors consisting of alpha and beta receptors. The parasympathetic nervous system has cholinergic receptors that are divided into nicotinic receptors in the skeletal muscle and muscarinic receptors in organs. The autonomic nervous system has three principal functions: to regulate the heart, regulate the secretory glands, salivary, gastric, sweat, those sorts of things, and regulate the smooth muscles of the bronchi, blood vessels, urogenital system, and the GI tract. The two subdivisions of the autonomic nervous system include the sympathetic nervous system, which is useful in highly stressful or emergency situations, and the parasympathetic nervous system, which maintains homeostasis and works in opposition of the sympathetic nervous system. The sympathetic nervous system is characterized as fight or flight, and the parasympathetic nervous system is characterized by rest and digest. Overall, the sympathetic nervous system has three main functions: to regulate the cardiovascular system, to regulate the body temperature, and to implement the fight or flight reaction. On the other hand, the parasympathetic nervous system has 7 regulatory functions that include slowing the heart rate, increasing the gastric secretions, emptying the bladder, emptying the bowel, focusing the eye for near vision, constricting the pupil, and contracting the bronchial smooth muscle. Notice emptying the bowel. The old adage that someone scared the stuff out of you is impossible, as it would not occur with sympathetic nervous system stimulation, but with parasympathetic. I put this diagram on a separate slide to enlarge it, but this diagram demonstrates the differences between the parasympathetic nervous system and the sympathetic nervous system. Drugs have been developed that mimic or block the sympathetic and parasympathetic nervous systems. Sympathetic drugs are used to regulate the heart, blood vessels, and lungs, and the parasympathetic drugs are aimed at digestion of food, excretion of waste, control of vision, and conservation of energy. Here are some semi-synonymous terms. The sympathetic nervous system is also called the adrenergic, especially when talking about receptors. A drug that mimics the sympathetic system is called sympathomimetic. The parasympathetic nervous system is also called the cholinergic nervous system. Often the terms cholinergic and muscarinic are used interchangeably. This is somewhat of a misnomer, as muscarinic receptors are only one portion of the cholinergic receptors. A drug that mimics the parasympathetic nervous system is called parasympathomimetic. Acetylcholine is the most common neurotransmitter of the peripheral nervous system. Norepinephrine is released by most postganglionic neurons, and epinephrine is released by the adrenal medulla. Dopamine may also serve as a peripheral nervous system transmitter. A synapse uses only one of these transmitter substances. You can see from this picture that acetylcholine is the main transmitter in the peripheral nervous system. Norepinephrine and epinephrine have a more limited role. Norepinephrine is the transmitter released by practically all postganglionic neurons of the sympathetic nervous system. The only exceptions are the postganglionic sympathetic neurons that go to sweat glands, which employ acetylcholine as their transmitter. Epinephrine is released from the adrenal medulla and not the postganglionic neurons. We are mostly concerned about the receptors of the peripheral nervous system in relation to drug actions. The cholinergic receptors are mediated by acetylcholine. The adrenergic receptors are mediated by epinephrine and norepinephrine. These are the three major subtypes of cholinergic receptors referred to as nicotinic N, nicotinic M, and muscarinic. Activation of nicotinic N standing for neuronal, receptors promotes ganglionic transmission at all ganglia of the sympathetic and parasympathetic nervous systems. In addition, activation of nicotinic N receptors promotes release of epinephrine from the adrenal medulla. This explains why nicotine or smoking raises blood pressure and increases heart rate. Activation of nicotinic M standing for muscle receptors, causes contraction of skeletal muscle. Activation of muscarinic receptors, which are located on target organs of the parasympathetic nervous system, elicits an appropriate response from the organ involved. These receptors are the ones that we are most concerned about in our understanding drug action. When we talk about cholinergic receptors, we are mostly referring to muscarinic receptors. The muscarinic and adrenergic receptors will be discussed individually. Centrally acting alpha-2 receptor agonists will be discussed in later presentations. For each receptor drug discussed, you will want to know the receptors that the drug affects, the normal response to activation of those receptors, and whether the drug increases or decreases receptor activation. So is it an agonist or an antagonist? Before we begin, we must explain the difference between an agonist and an antagonist. Agonists and antagonists act in opposite directions. When an agonist produces an action, antagonist opposes the action. Agonist is a substance which combines with the cell receptor to produce some reaction that is typical for that substance. On the other hand, antagonists are chemical which oppose or reduce the action. In this diagram, an agonist binds to a receptor and the receptor is activated. Signal transduction occurs and the outcome is a biological response. When an antagonist binds to a receptor, the receptor is blocked for binding by any agonist. There is no biological response. Here are the organs and tissues affected by muscarinic receptors. The effect of an agonist and the effect of an antagonist are listed. You must know these effects. Bifenacol is a muscarinic agonist. It mimics the effects of acetylcholine at muscarinic receptors. Bifenacol is used to treat urinary retention, but because of the additional receptors that are stimulated, side effects include bradycardia, hypotension, diaphoresis, abdominal cramps, and meiosis. Pilocarpine can be systemic for xerostomia or ophthalmic for glaucoma. Atropine is a muscarinic antagonist or an anticholinergic. We won't be discussing this as it doesn't have much of a role in primary care. The cholinesterase inhibitors, represented by neostigmine and physostigmine, which are parenteral, and pyridostigmine, which is oral, prevent the breakdown of acetylcholine by acetylcholinesterase. As a result, more acetylcholine remains available to activate cholinergic receptors. These drugs are used for treatment of myasthenia gravis. Donepezil, galantamine, and rivastigmine are used for treatment of Alzheimer's disease. These drugs work on receptors in the central nervous system. We will be discussing them in another chapter. Ganglionic stimulating agents, represented by nicotine, selectively mimic the effects of acetylcholine at nicotinic N or neuronal receptors of the autonomic ganglia. These drugs have little therapeutic value beyond the use of nicotine in smoking cessation programs. Ganglionic blocking agents, represented by mecamylamine, selectively block ganglionic nicotinic N receptors. I haven't heard of mecamylamine for hypertension treatment, and it is not in the hypertension guidelines, so you don't really need to know this. Neuromuscular blocking agents, represented by tuberculin and succinylcholine, selectively block the effects of acetylcholine at nicotinic M for muscle receptors at the neuromuscular junction. This causes paralysis. These are used in surgery and not in primary care. Urinary antispasmodics include synthetic antimuscarinics such as oxybutynin and tolterodine. There's been a beta-3 blocker created called mirabegron, which is Myrbetriq. Beta-3 receptors are located on the gallbladder, urinary bladder, and brown adipose tissue. I didn't know that I had brown adipose tissue. Here are the actions of alpha-1 adrenergic receptors upon activation with an agonist and an antagonist. These are all listed for you on a separate handout. We will not be covering alpha-2 receptors except for central alpha-2 receptors in another presentation. Alpha-2 receptors really have little significance in pharmacology. We will not be discussing many of the alpha-1 adrenergic agonists such as epinephrine, norepinephrine, and dopamine. The Catecholamines are used in the hospital and in intensive care and not in primary care. You do have a handout for emergency epinephrine injection devices. You do need to know this information. The only other time you may see epinephrine in primary care would be mixed with xylocaine for a local anesthetic, but I don't believe most practices have this either. The xylocaine in my office is without epinephrine. Ephedrine is a mixed-acting agent that causes norepinephrine release and also activates alpha and beta receptors directly. In primary care, it can be used as phenylephrine as a nasal spray to reduce nasal congestion through vasoconstriction. It can also be taken orally as pseudoephedrine. It also decreases nasal congestion to vasoconstriction. The products containing ephedrine can raise the blood pressure, so should be used with caution in patients with hypertension. Both products are available over the counter. Adverse effects of ephedrine include hypertension, dysrhythmias, angina, and hyperglycemia. In addition, because ephedrine can cross the blood-brain barrier, it can act on the central nervous system to cause insomnia. All of the OSINs are selective alpha-1 blockers. There are non-selective alpha blockers, which block alpha-1 and alpha-2 receptors. These are not used in primary care. Tamsulosin and alfuzosin and others are used strictly for benign prostatic hypertrophy, as they block alpha-1 receptors on smooth muscle of the bladder neck, prostatic capsule, and prostatic urethra. The blockade of vascular alpha-1 receptors is weak, so these drugs are not indicated for hypertension. Hypotension is a significant adverse event with all alpha blockers and can lead to falls, fractures, and head trauma. They can also cause reflex tachycardia and nasal congestion. You need to forewarn patients about first dose hypotension. Advise them to sit or lie down if dizziness or lightheadedness occurs on standing. Teach patients to move slowly when changing from a supine or sitting position to an upright posture. Urge them to avoid driving and other hazard activities for 12 to 24 hours after the initial dose. Reinforce taking the initial dose at bedtime to minimize the first dose effect. This slide summarizes the effect of agonist and antagonist of beta-1 adrenergic receptors in specific organs and tissues. Beta-1 agonists are not used in primary care. Beta-1 antagonists are used in primary care. The beta-1 antagonists are divided into cardioselective, primarily beta-1 antagonist, or non-selective, beta-1 and beta-2 antagonists. The effects of beta-1 antagonists are reduced heart rate, reduced force of contraction that decreases oxygen demand of the heart, and the slowing of impulses through the AV node. Beta-1 adrenergic antagonists are indicated for angina, hypertension, but not as a first-line drug, cardiac dysrhythmias, especially tachyarrhythmias, MI, reduction of perioperative mortality, heart failure, hyperthyroidism, migraine prophylaxis, performance anxiety, pheochromocytoma, and glaucoma. Cardioselective agents may be used in asthma or COPD. It may actually reduce COPD exacerbations and improve survival. You have a handout that compares all of the oral beta blockers. We will be revisiting this topic under hypertension. This is just for generalities. This slide summarizes the effect of agonists and antagonists of beta-2 adrenergic receptors and specific organs and tissues. Albuterol, ProAir, Provento, Ventolin, Vospire, can reduce airway resistance in asthma and COPD for that matter by causing beta-2 mediated bronchodilation. And this is because albuterol is relatively selective for beta-2 receptors and not beta-1. Remember, however, that receptor selectivity is only relative. If administered in large doses, albuterol will lose selectivity and activate beta-1 receptors as well as beta-2 receptors, resulting in the adverse effects of tremor and tachycardia. Non-selective beta blockers are used to lower blood pressure to treat heart failure. They work by vasodilating and decreasing vascular resistance and allow for more blood flow to the heart. In addition to the beta-1 effects, stimulation of beta-2 receptors causes bronchoconstriction, vasoconstriction, and reduced glycogenolysis. Non-selective beta blockers are more likely to worsen peripheral vasoconstriction or bronchoconstriction, delay recovery from hypoglycemia in type 1 diabetes, and impair exercise performance. We will cover most of the specific drugs again in other presentations. It's essential that you learn the receptors and the effect of agonists and antagonists on the receptor functions. Knowing the actions of receptors helps you to determine the drug action and adverse effects. Thank you for your time and attention.